Hello, everyone. Good morning, good afternoon, good evening. It's Dr. Kaz, and this is the next installment in our respiratory system learning. So let's pick up with where we left off. We were learning about the nervous control over our respiration, and now we're going to talk about a couple concepts here: airflow, pressure gradients, and resistance. So when we're discussing airflow, we're discussing the air that is going to be moving in and out of your lungs each time you take a breath. That's dependent on two things: pressure gradient, which we spent a lot of time talking about in our previous video, right? That is going to be the pressure of air, all right? In the atmospheric pressure, that is going to be the pressure in the room that you're sitting in right now, or if you're outside. And then the other pressure that we're going to be talking about is the intrapulmonary pressure. That's the pressure in your inside your lungs, specifically in the alveoli. The other factor is resistance. And there's three things that are going to affect resistance. And that is going to be what the conditions are in your airways, what the conditions are in your lungs, and the conditions within your chest wall. So we're going to work through these and talk about some of these. Okay, so this formula should look familiar. Flow is equal to a change in pressure, or the pressure gradient, right, over or divided by resistance. So when we're talking about the change in pressure, or delta P there, right, that's our pressure gradient. And our pressure gradient is going to be the difference in air pressures, all right, within your lungs and the atmospheric pressure, the pressure in the room or outside where you are. So we refer to that as the pressure gradient. So that is a difference. We'll need both of those values. Atmospheric pressure is usually going to be constant, always at 760 millimeters of mercury, or 1 atmospheric unit, unless otherwise noted. Right? And then you should have the other value, the intrapulmonary pressure too. You take the difference of both of those and you have your pressure gradient. Then you're going to divide that by the resistance and you'll have flow. So we've seen this before when we were studying the heart or the circulatory system. Same equation, but now instead of our pressure gradient being applied to liquid, our pressure gradient is now applied to gas, our air. So the flow is going to be directly related to the pressure gradient. That means if the pressure gradient increases, flow will increase, right? But it will be inversely related to resistance. That means if the resistance increases, airflow decreases, right? And vice versa. Okay, so keep that in mind. You're familiar with this equation. Now we're just going to apply it to the lungs. So when we're discussing our pressure gradient, right, one of the ways that we can increase, all right, our pressure gradient is to change the volume of the thoracic cavity. We spent quite a lot of time talking about that, all right, in the previous video. Now, normally with eupneic breathing, okay, or what we call quiet breathing, we are going to see about 500 millimeters of air, all right, moving into and out of the lungs with each breath. So if we want to increase that amount, what we need to do is increase the volume. And by doing so, by increasing the volume, we are going to change our pressure gradient, and we are going to increase that pressure gradient, thereby increasing airflow. Okay, go back to the equation here. All right, here's our pressure gradient. If we increase the volume in the thoracic cavity, taking deeper breaths, right, we will increase the amount of air entering into the cavity. We're going to increase that pressure gradient. And by doing so, we are going to increase the airflow there. Now, with resistance, right, these are going to be the factors that are going to challenge us in moving air in and out of our lungs. So a couple things that can affect the resistance is the elasticity, of the lungs and or the chest wall. Those two things, all right, elasticity can affect. We can also change the diameter of our bronchioles. And we're somewhat familiar with that when we were talking about blood flow. We can increase the resistance, all right, in the equation for blood flow by changing the diameter, the lumen size of the arteries. Same scenario here. And then another factor that can affect resistance is if we collapse the alveoli. We're going to talk about these in more detail here. Okay, so for resistance, if we decrease elasticity, right, we are going to increase the resistance there. And we see this is part of the normal process of aging. We talked about this in our Bio 210 class. As we age, right, our body produces less elastic fibers, less collagen fibers, less a lot of other things, right? But the elastic fibers are important here. If we are producing less or fewer and fewer elastic fibers, right, then our elasticity decreases. Also, we will see, all right, folks that have a really bad scoliosis, especially in the thoracic region there, all right, that scoliosis can also impact, all right, the elasticity of the lungs. All right, we'll also notice that in folks with osteoarthritis, right, in the vertebrae and also in the thoracic cage there, makes it difficult for those joints, right, for the costal cartilage joints, for the ribs to move. That will then make it more difficult for changes in the thoracic volume of the chest cavity there. And the condition of pulmonary fibrosis, if you're ever taking boards, medical boards, this is usually the #1 answer to a decrease in elasticity in the chest wall, right? Because of pulmonary fibrosis, the term fibrosis, right, is talking about scar tissue formation. So what we see in this condition with pulmonary fibrosis, the elastic tissue gets replaced with scar tissue. Scar tissue, right, predominantly is going to be collagen. Collagen is not elastic. Right, another factor that's going to affect our resistance is going to be the diameter or the lumen size of our bronchioles. So that is an inverse relationship. So that means if we increase the lumen, all right, or if we bronchodilate, right, those structures, right, that means the lumen gets bigger, then we are going to decrease the resistance. The larger the lumen, okay, the easier it is for the air to flow through. And so our sympathetic nervous system is going to cause bronchodilation, whereas our parasympathetic nervous system is going to cause bronchoconstriction. Also epinephrine. For those of you that have been fortunate enough to never experience, all right, the use of an EpiPen, right, because you get anaphylactic shock, usually because of a severe allergic reaction, a hypersensitivity reaction, right? One of the symptoms that people are suffering from is severe bronchoconstriction. So when the EpiPen is administered, right, the epinephrine will cause bronchodilation, increase the lumen size so those folks can breathe, all right, easier. Bronchoconstriction, all right, of course, that will decrease, all right, the size of the lumen, therefore increasing our resistance. As I mentioned before, the parasympathetic nervous system causes bronchoconstriction. Also the release of histamines. Thank you, mast cells and eosinophils, right? That is essentially what will occur during a hypersensitivity reaction. Or for those of you that have lived in cold weather climate like I did growing up, whenever I stepped out into the cold, I suffered from asthma. I would usually have to take a couple hits off of my rescue inhaler because of the bronchoconstriction that would occur. Now, bronchoconstriction, or when we're dealing with resistance, we can also occlude these breathing passages, right? And that will also increase the resistance, usually because of some sort of obstruction that comes from something specific, all right, like phlegm, mucus, all right, inflammation can cause this, or something physically gets stuck in there. All right, for example, a pee, all right, just happens to jump into mind because sometimes if people, for whatever reason, food goes down the wrong pipe, as they say, it can cause an obstruction or an occlusion to occur, and that will also increase the resistance. And the last factor that can affect resistance is going to be our alveoli. If you have a collapsed alveoli, that causes an increased resistance. What can cause that? When the type 2 alveolar cells are not producing surfactant, right? Surfactant, all right, help to our alveoli, okay, to stay inflated. And that has to do with the surface tension on these alveoli. And unfortunately, surfactant isn't produced, all right, early on when you are developing as a baby inside of mommy, all right? So if you were born premature, usually before the 25th week there, you haven't really had time to produce surfactant, and that's why premature infants, all right, that are younger than that are usually on a ventilator to help them breathe. If you're close to that time, usually you can steroids can help produce surfactant, get the alveolar type 2 cells to produce surfactant. Right. So when they collapse, we will see an increase in our resistance. And so when the alveolar collapse, we call this condition respiratory distress syndrome, or RDS. All right, so compliance here, this is an important term because it describes, all right, how easily, all right, the lungs and the chest wall expand, all right, when you are breathing. And so compliance is determined by two things: surface tension, right, and the elasticity of both the chest and the lungs. So the easier it is for the lungs to expand, the greater the compliance, and therefore, all right, the more difficult it is for the lungs to expand, all right, the less the compliance. So you'll see here, all right, several conditions that help to increase the resistance to airflow. So they increase the resistance. This is me, all right, Mr. Asthmatic, all right, that is going to affect, all right, the lumen size of my bronchioles. So when you have bronchoconstriction, all right, that most asthmatics suffer from, all right, they will have a decreased lumen size there, thus increasing resistance. Also, pulmonary fibrosis there. Like I said, that's going to affect the compliance, the elasticity, all right, that allows the chest wall to expand and the lungs to expand. We have now replaced the elastic tissue with scar tissue. So they don't have that elasticity there, so it's much more difficult for those to expand. And as a result of this, all right, people like us have to breathe much harder. And therefore, if we're putting more effort into our breathing, we are going to be burning through a lot of ATP. So folks, all right, that have these types of respiratory disorders, right, especially if it is a chronic type of respiratory disorder like pulmonary fibrosis is, right, you will see that these folks often look tired. And you can go, all right, anywhere from 4 to a 6-fold increase in your energy requirements. Percentages here go anywhere from 5 to 25% of your body's total energy expenditure, which is quite a bit. So you'll see folks too, like folks with emphysema, which we'll talk about that condition here shortly. Folks, you have to forgive me, my just a little bit under the weather as I'm making this video, so just bear with me if I sound awful, okay? Trust me, I sound a lot worse than I feel. All right, so pulmonary ventilation. We were talking about this in our last video here, and this is us discussing how, all right, air is moving into and out of the lungs, specifically into and out of the alveoli. So when we're talking about pulmonary ventilation, we're going to look at how much air is moved, right, from the room that you're sitting in into your alveoli over a period of time. And that period of time is going to be 1 minute. So the first term there, tidal volume, we talked about that before. That's the amount of air that you move in and out of your lungs when you take a breath. During normal quiet breathing, that's about 500 milliliters. All right, the respiration rate, all right, in a normal individual and a normal, healthy individual should be anywhere from 12 to 15 breaths per minute. So all we're going to do is we're going to take those two values and we're going to multiply them to one another, and that's going to give us our pulmonary ventilation. So tidal volume, 500 milliliters, times breaths per minute, which in this example is 12. That's roughly about 6 liters of air, all right, which is going to reach your lungs in a minute. All right, real simple pulmonary ventilation for you. All right, so let's talk about a couple other terms here. Anatomic dead space, alveolar ventilation. All right, anatomic dead space, we're discussing, all right, what's going on in the conducting zone. Okay, so you have the conducting zone, which we're not going to see any exchange of gases occurring in this area, and that's in the upper respiratory part of your lungs, right, and pretty much down into, all right, a good portion of the bronchial tree there, right, and so your anatomic dead space usually measures about 150 milliliters. Now the alveolar ventilation is how much air is going to make it into your alveoli, all right, per minute. So we saw here when we're talking about pulmonary ventilation, how much air is entering, all right, your lungs, all right, from the atmosphere. And now when we're talking about the alveolar ventilation, now we're going to talk about the amount of air that is actually making it down into the alveoli. So real simple, all we're going to do is we're going to take the tidal volume, all right, and we're going to take the difference of the tidal volume and the anatomical dead space. So normally tidal volume is about 500 milliliters. Excuse me. It's about 500 milliliters. And we're going to subtract the anatomic dead space, which in this case is about 150 milliliters. And then we're going to multiply that all right, we're going to multiply that by your respiratory rate. Again, 12 breaths per minute. So that's going to, when we calculate that out, that's roughly 350 milliliters times 12, and that comes to about 4.2 liters per minute. So if we want to increase our alveolar ventilation, all we have to do is take deeper breaths. We need to increase this number, our tidal volume. How do we do that? All right, when we take deeper breaths, we're going to increase the thoracic cavity volume, thereby increasing airflow, because we're changing the pressure gradient when we do that. Increase the pressure gradient, as long as the resistance doesn't change, will increase the airflow, right? Therefore, we'll increase our tidal volume, and therefore we will increase our alveolar ventilation. All right, so our physiological dead space, right now what we're going to do is, right, figure this out. We're going to take the normal anatomic dead space, which is about 150 milliliters, and then we are going to take any loss of alveoli that can occur for whatever reason. All right, say you had suffered from some sort of respiratory disorder, right? You had an infection of some sort, for example, pneumonia, right? And we've damaged, all right, some of the alveoli from the pneumonia. Maybe you had COVID-19. Again, you damaged some of that epithelium there. And as a result, okay, you are going to increase the physiological dead space because you've increased the loss of alveoli. All right. So in a healthy individual, all right, our anatomical dead space should be just in that conducting zone. All right. Now, again, you will see, all right, that almost everybody has some sort of loss of alveoli, right? But unless otherwise mentioned, you want to consider the dead space, all right, to be about 150 milliliters, all right, because that's the conducting zone there. But again, someone like myself, now a lot of people, because they probably had COVID and had some respiratory issues going on because of that, their physiological dead space is probably increased because they may have lost some alveoli. All right, this brings me here to our spirometer. This is a fun device. Actually, that's me dripping sarcasm as I say that. I've had to use this device many times. And basically what it does is it's going to measure, all right, our respiratory volume. And so we have 4 different volumes that we are going to measure using our spirometer there. And so it gives us a good indication, all right, to an individual's respiratory health. So the 4 values that we have are tidal volume, inspiratory reserve volume, expiratory reserve volume, and then residual volume. So all of these volumes are going to be measured by the spirometer. So the tidal volume, again, that's what we measure during our quiet breathing. So as you are sitting here watching this video, listening intently to my words, right, you are undergoing quiet breathing. All right, that's eupneic breathing. So this spirometer will measure that. Then, if we want to measure the inspiratory reserve volume, all I'm going to ask you to do is take a deep breath in, as big as you can. Right? And so the inspiratory reserve volume is the amount of air that you take in past the tidal volume. This measures compliance, right? The ability for your chest wall to expand and for your lungs to expand. So I'm going to show you here, all right, on a spirometer reading here. You'll notice, all right, in the middle of our chart here or drawing, here is tidal volume, these little waves here. All right, tidal volume is roughly going to be about 500 millimeters. Then I ask you to take a deep breath, all right, take a big deep breath. That is going to be your inspiratory reserve value. That is beyond the tidal volume. So we take a deep breath in and we'll measure that. So here our patient is taking a deep breath in. And so beyond the tidal volume, that's the inspiratory reserve volume. Then we have the expiratory reserve volume. Okay, similar. In this case now, we're going to ask the patient to take a forcible exhale. Okay, so we'll say, all right, just breathe regularly and now blow out as hard as you can. All right, I didn't really explain to you what a spirometer was, but it's this device that you put up to your mouth and you breathe through it. You're going to inhale through it and exhale through it. So you'll breathe through it, do a couple breaths for the tidal volume, and then the person administering the test will say, okay, all right, now blow out as hard as you can, and you'll blow out as hard as you can. And that's going to be measuring your expiratory reserve volume, which is, all right, the amount of air that you forcibly exhale. Again, it's going to be beyond the tidal volume. Does not include the tidal volume, but it'll be beyond the tidal volume. This is going to measure the elasticity. So for example, a person that has pulmonary fibrosis is going to have a horrible, all right, expiratory reserve volume. So if we look here, okay, again, you'll notice we have the person take a couple breaths, just breathe regular. So they're breathing regular. And then when I tell you to breathe out as hard as you can, and they breathe out as hard as they can. And so we measure the expiratory reserve volume, all right, beyond the tidal volume. And that's what we see here. So that is our third volume. Our last volume, all right, that we measure is called the residual volume. And this is the amount of air that is going to be remaining in your lungs after you blow out as hard as you can. So this is essentially the leftovers. After you have breathed out as forcibly as possible. So that's what you're seeing here at the bottom. Right there. That's the residual value. All right, so those are the 4 volumes that we are establishing. Now remember, how did we get this value here? 6,000 milliliters, AKA 6 liters here. This is how we did it. We figured out the pulmonary ventilation, okay? Measure your tidal volume, then we multiply it by the number of breaths in a minute. And like I said, normally it's about 6 liters or 6,000 milliliters. That's how we get that. So we have our 4 volumes here. Now, what we're going to do is we're going to take those 4 volumes and calculate out what we call our 4 capacities. So what we'll do is, right, the 4 capacities are the inspiratory capacity, the functional residual capacity, vital capacity, and then total lung capacity. So the inspiratory capacity, again, what we'll see here is we're going to take the tidal volume. Now this time we're going to include tidal volume. And then we are going to add the inspiratory reserve volume to the tidal volume. So let's take a look at our picture. So you'll see here, all right, here's our tidal volume, those little ups and downs right here. So now what we're going to do is we're going to measure tidal volume all the way up to the top of that big deep breath in that you took. And all of those values, all right, or numbers are going to be what we use to calculate the inspiratory capacity. All right, then, right, if we want to calculate our functional residual capacity, all right, this is basically the amount of air that's left over, all right, after you have taken a breath out during normal breathing, during yipnic breathing, okay? So at the end of a breath out, you'll see here, right, you have your functional residual capacity. You've exhaled, and this is how much is left over. So we'll include, all right, the residual volume, all right, and we'll take the expiratory reserve volume. Vital capacity is used quite a bit. And this is the amount, all right, of air that you're going to be able to breathe in and out during forced breathing. For example, exercise, right? It's wonderful value to have. So you have an understanding, all right, of how much air you are breathing in and out during exercise, pretty intense exercise. So all we're going to do here is we're going to take tidal volume and both the inspiratory and expiratory reserve values. So we take our tidal volume, then we take our inspiratory reserve volume and our expiratory reserve volume. Here's vital capacity right here. It's pretty much everything except the residual volume, because the residual volume is the amount of air left in your lungs when you are breathing. After you've taken, after you've taken the deep breath out. And then of course, what's remaining is the total lung capacity. And that's obviously, all right, the amount of all the volumes, including the amount of air that is left in your lungs. And so this tells us the maximum amount of air that you can actually hold in. Very important to know that. Okay. 2 other things that you should know when we're talking about respiratory measurements. All right, here, all right, we are going to discuss the rates now of which air moves in. So of course, this is one of the things that I hated about doing a spirometer reading, was actually doing the forced expiratory volume, or the FEV. We have FEV1, FEV2. All right, but basically, all right, these FEVs are going to be, we're going to ask the person, all right, to take to breathe regular, all right, and then what we'll do is we are going to have them blow out as fast as they can, as hard as they can for 1 second. So just breathe regular, and then when I tell you to, blow out as quick as you can, whew, and as hard as you can. And so in a normal healthy person, they are going to be able to exhale anywhere between 75 to 80% of their vital capacity. But those of us, all right, for myself, an asthmatic, all right, emphysemic patients, someone with pulmonary fibrosis, all right, their forced expiratory volume will be decreased, right, because they can't blow out as hard, right, because their lungs are lacking in that elasticity there. Okay, and then the last one is the maximum voluntary ventilation, also known as MVV. This one here is probably the worst part about the test. All right, what we'll do is we'll have the person take a couple normal breaths, and then we'll say to them, all right, what I want you to do is when I tell you to, I want you to blow as hard as you can for as long as you can. All right, so here we go. Breathe in and breathe out as quickly as you can. And then when I tell you to, blow out as hard as you can. And so this is what will happen. They'll do this. And again, what we're going to see is with this value, it could be as high as 30 liters within a minute, which is actually pretty good, right, in a healthy individual. But of course, right, folks with any type of respiratory disorder, someone with pneumonia, someone with asthma, someone with emphysema, all right, pulmonary fibrosis, they're going to have a much lesser MVV because they are going to be impaired during that time when they're trying to breathe out. Okay, this brings us to, all right, our next part of the respiratory system. And we're going to be talking now about what happens during gas exchange. And we're going to be talking about the different chemical principles that affect gas exchange. So partial pressure, you're probably going to get tired of talking about pressure, but this is important. So we're going to talk about partial pressure and then Dalton's law. All right, so the definition of partial pressure is going to be the actual physical pressure exerted by a gas, all right, one specific gas that's within a mixture of gases, all right? And we measure that using milligrams of mercury. So for example, we're talking about partial pressure, all right? Our atmosphere is made up of several different gases, all right? Nitrogen is the predominant gas, that's about 79%. Then oxygen is anywhere between 20 to 21%. So those two gases make up the majority of the gas in the atmosphere. All right, so when we're talking about partial pressure, when we have a mixture of gases, we're going to talk about, all right, how much pressure each individual gas is going to measure. And so normally when we're discussing partial pressure, we're going to annotate it with a P in front of the gas symbol. So obviously the partial pressure of oxygen, we whatever, I can't talk tonight, all right? We're going to annotate it as PO subscript 2. All right, if we're talking about carbon dioxide, it would be PCO2. All right, so when we're discussing partial pressure, we're going to be talking about each individual gas moving independently, all right, from the other gases down its partial pressure gradient. So similar to, all right, remember our pressure gradients that we were talking about before? All right, all we're now saying is, all right, with the partial pressure of gases is each individual gas is going to move independently. It doesn't care what the other gases are doing. It's only going to care about itself, and it's going to move down its own pressure gradient or partial pressure gradient when we are having gas exchange. So we're going to talk about how this occurs in the alveolar, in the lungs. And then we'll also talk about it when those gases are diffusing between the cells, the systemic cells in the blood. Okay, so keep in mind, our atmospheric pressure is 760 millimeters of mercury, and that is at sea level. So we're going to add up all the individual pressures of all the gases in our immediate environment, in this room, all right, or outside. And all of those will equal this number here. All right, so there's our nitrogen, there's our oxygen. All right, we'll even have some water vapor there. We'll have argon, there's several other gases, I think xenon's in there. All right, but several other gases, all right, which are going to cause, all right, or contribute to our total pressure or atmospheric pressure of 760 millimeters of mercury at sea level. All right, so how do we figure it out? Easy, easy, easy. All right, so if we know, like I said, that's about 79%, all right, or 78.6% of the total gas in the atmosphere is nitrogen. So we just multiply 760 millimeters of mercury by 78%, and that will give us the partial pressure of whatever that gas is going to be. And then we'll add up all the partial pressures, and that will give us our total atmospheric pressure, which if we're at sea level should equal that number. So when we discuss Dalton's law, all Dalton's law is saying the total pressure in a mixture of gases, atmospheric pressure, for example, is going to be equal to the sum of the individual partial pressures. And that's it. That's Dalton's law. Must be pretty nice to have a name of a law named after you. Seems pretty obvious to me. All right. So when we're dealing with our partial pressure gradients, all right, when we have gradients existing, same principle is going to apply. The partial pressure for a gas, all right, needs to be higher in one region of the respiratory system compared to another. And when it is, all right, that will mean that that gas is going to move from an area that has a higher partial pressure to an area that has a lower partial pressure. And it'll keep moving until it reaches equilibrium. Folks, you should know this, meaning this concept. Right? We talked about it with diffusion, with concentration gradients, all right? As long as there's a concentration gradient, a difference in the amount of substances in two areas, if there's more in one area and less in another, all right, it's going to want to flow down its concentration gradient. Right? We talked about it during the cardiac cycle, right, with the movement of blood. Right? Blood moves from an area of high pressure to low pressure. Well, folks, we're just changing, right? We're just changing, right? The matter, the phase of matter that we're dealing with. We're going from a liquid now to a gas. In the same, but the similar concept, right? You have an area of high partial pressure and an area of low partial pressure. And so that gas is going to want to move from an area of high pressure to an area of low pressure, right? So this is very important. So this gas exchange that we're going to see in the lungs is heavily dependent on the gradient that exists there. So we're going to see it in two places when we're talking about the respiratory system. We're going to see the exchange of gases in the alveoli and the pulmonary capillaries. And we're also going to see the exchange of gases, right, between the systemic cells and the systemic cell capillaries. And so we're going to talk about that whole process here. All right, so keep this in mind, right? So our partial pressures, right, are going to be different inside of our body than outside of the body. And there's a reason for that, because as the air moves into our body, right, for one, right, it's going to get humidified. I've discussed this in 210, all right, when I was talking about the inferior nasal concha, and as you were taking a breath in, all right, those bones in the nasal cavity cause turbulence and cause the air to swirl around in your nasal cavity, one, to clean the air, but also to humidify the air. So now we're going to throw in water vapor into the air that you're breathing in. So the water vapor in the air that you're breathing into your body, okay, as you humidify it, we'll see that there's more water vapor in the air that you're breathing into your alveoli than in the atmosphere. We'll also see, all right, this point being is we're going to alter, all right, some of these partial pressures here as they enter into the body, right, into the alveoli, right, from the atmospheric area in the room that you're sitting in or if you're outside. So this air is going to mix, right, with the air that we find in the anatomic dead space because there's no diffusion there. So the air coming in from the environment will mix with the air in the anatomic dead space. That is going to affect, all right, some of those partial pressures there. Because the partial pressure of oxygen, all right, is going to be in the atmosphere about 152 millimeters of mercury. But we're going to find out by the time it gets down to the alveoli, it's about 104 millimeters of mercury. And so this is because it undergoes some changes as it transpires, as it moves, all right, through the conducting zone there down into the respiratory zone. So, but the concept here, though, that I want to get to you is when we get to the alveoli here, right, the partial pressure of oxygen, like I said, is about 104 millimeters of mercury. And in the atmosphere, it's about 152. But keep in mind, when you look at those two values, all right, oxygen wants to move down its partial pressure gradient. So oxygen wants to move into the lungs because there's less partial pressure there. Now, if we flip that for carbon dioxide, it's different. All right, carbon dioxide partial pressure, all right, is going to be greater in the lungs than it will be in the atmosphere. So because of that, carbon dioxide will want to move down its partial pressure gradient and get out into the atmosphere. Okay. All right. So let's talk about how this is going to relate, right, to our systemic cells here. When we're dealing with the systemic cells, keep in mind your cells are going to be undergoing their normal metabolic functions. So what happens during our metabolic functions? We need energy. What's the best way to generate energy? Aerobic cellular respiration. Okay, if you have oxygen, you can generate quite a bit of ATP off of one molecule of glucose, for example. Roughly about 32 molecules of ATP can come from one molecule of glucose. It's pretty good, right? So that means we need oxygen. We need oxygen for that process. So the systemic cells want oxygen. But at the same time, all right, as they undergo metabolism, one of the waste products, all right, for their cellular metabolism, all right, for respiratory gases is going to be carbon dioxide. So when we're in the systemic cells, we are going to have a relatively low amount of oxygen in the systemic cells, but we are going to have a relatively high amount of carbon dioxide in the systemic cells when we compare those two respiratory gases to their content in the alveoli. Okay, so keep that in mind. In the lungs, we have lots of oxygen because we're breathing it in. In the lungs, we usually have a lot less carbon dioxide. But when we get to the systemic cells, that changes, right? And I'll get into that in a little bit. If you're confused, not to worry. I will take you under my wing. I will guide you. Right. So when we are doing what we're doing right now, when we are resting and just hanging out, right, these partial pressures are going to remain constant. So a lot of these values will go unchanged. Now it varies when you start to exercise. There's a lot of other factors involved. But for right now, this is just going to be under resting normal conditions. Right? Resting normal conditions. But here's the thing. when these gases are circulating in your blood from your lungs to the systemic cells, all right, this is very important. Their partial pressures are not, I repeat, are not constant. They will change. And you're thinking, oh my gosh, she's making this more complicated. I'll explain to you what I meant by that, okay? You'll see it all with numbers. Okay, so for the most part, when we're talking about the movement of respiratory gases, oxygen is going to enter into the blood, the pulmonary capillaries, from the alveoli. As it enters, carbon dioxide leaves. As you exhale, you'll blow it off. Then when oxygen gets down to your systemic cells, it's going to leave your blood and enter into the cells, whereas carbon dioxide is going to exit the cells and enter into your blood. So it travels back to the lungs and you can breathe it off. That's what we're trying to do. And that's what we're seeing here. Quick review. Remember our circulatory system, you have two circulatory systems. You have the pulmonary circulatory system, and that's the blood that travels from the heart to the lungs and then back to the heart again. All right, that's our pulmonary circulation. Systemic circulation is from the heart to all the cells in the body and then back to the heart. That's your systemic circulation. All right, keep that in mind. All right, here we're going to talk about, I'm not going to spend a lot of time on this because I'm going to get into much more detail. But when we look at this diagram, we're looking at an alveoli. And basically, we're seeing here in the lungs, the partial pressure of oxygen is 104 millimeters of mercury. And it's less here in the pulmonary capillary. So just follow the red arrow. The red arrow is telling you that oxygen, because it has a higher pressure here and a lower pressure here in the pulmonary capillary, is going to exit the alveolus and go into the blood. Remember, it's going down its concentration gradient. Vice versa for carbon dioxide. Carbon dioxide has a partial pressure in the pulmonary capillary, 45 millimeters of mercury, but in the alveoli, it has 40 millimeters of mercury. Greater here, less here. Follow the blue arrow. Carbon dioxide goes down its pressure gradient and goes into the lungs. And then you can see this value here is showing you, all right, the new partial pressure, because once oxygen has entered into the blood and carbon dioxide has entered out, here is the partial pressure that we see, all right, in the pulmonary capillary heading down out to your systemic cells. So it's the same. You see, partial pressure of oxygen is going to be the same here immediately in the pulmonary capillary. But that's going to be different because look, now we're going here into our tissues and you'll see the partial pressure of oxygen is now 95 millimeters of mercury. Hey, Dr. Kaz, that's not constant. Well, you can't get mad at me because I told you right here, right? In circulating blood, the gas partial pressures are not constant. That's what I'm talking about. They will not be constant in circulating blood. Didn't lie to you. Told you the truth. Spoke the truth. All right, so we'll get into this in more detail here, but I just wanted you to see that. All right, but I do want you to notice here, all right, we're looking at the alveoli, and the alveoli are lined by, all right, epithelium, which is simple squamous epithelium, or alveolar type 1 cell, all right, is attached to the endothelium. Endothelium are the epithelial cells that line vessels, that includes lymphatic vessels and blood vessels, and they share the same basement membrane. But look how thin that is. That's only 2 cell layers thick. That's one of the thinnest possible barriers in your body, which is great. Simple epithelium is great for filtration. It's great for absorption. It's great for secretion. So that's what we're seeing here. Our respiratory membrane is so pencil thin. Well, it's much thinner than a pencil, all right? But see what I'm saying, though? Very thin, and that's what we like. We want it to be thin. If this gets thickened for some reason, say an infection, you get inflammation here, then it's more difficult for respiratory gases to diffuse across that membrane. More on that later. All right, so staying with the chemical principles of gas exchange, let's talk about gas solubility and another law called Henry's law. All right, Henry's law, right, when we're at a specific or given temperature, the solubility of a gas, that means the ability of a gas to go into a solution, dissolve into a solution, is going to be dependent on two things: the partial pressure of the gas and the solubility coefficient of that gas in the liquid. Now, the solubility coefficient, all right, this coefficient is going to stay constant. It should not change for the gas. We'll get into that in a second here, but I want to talk to you about partial pressure. Think of partial pressure, all right, this is the driving force. This is what pushes, all right, whatever gas we're talking about into a liquid. So for example, carbonated beverages, right? I have some carbonated water around here somewhere. Well, actually, I was drinking a Coke. That's perfect, right? Coke is carbonated. It's carbonated with carbon dioxide, all right? So what we're talking about is, all right, the partial, how do I carbonate that drink? I have to drive that carbon dioxide into the liquid. And so basically I have to force it in there, right, using a pressure, right? The higher the pressure, the more I'm able to force that gas into a liquid form. So when you open that Coke can and you get that fizzing, that's the gas coming out of the solution. All right, it's reverting back to its gaseous form. And that's what we're talking about here, all right, with gas solubility, right? The partial pressure is that pressure that we have to exert on that gas to force it, to push it into the liquid, to get it to go into the solution. All right, the solubility coefficient, all right, this talks about, all right, how much gas that is going to be dissolved into a specific amount of liquid, all right, with a given temperature. Remember, all right, Henry's law is we're dealing with a given temperature and a specific amount of pressure. All right, without boring you, again, this is just going to depends on how the molecules between the gas and the liquid, whatever you're trying to force that gas into, how those molecules are going to interact with one another. So this is important, right? Because carbon dioxide is way more likely to go into solution than oxygen. It is way more likely to dissolve right into, all right, your blood, okay? So when we're discussing the solubility of gases, gases are going to vary in their solubility in water, meaning some gases will go into water much easier. They'll dissolve into water much easier. Some won't. Carbon dioxide, for example, way better going into water than oxygen is. Right? Nitrogen is horrible, horrible. Right? And so that's the problem. All right, with nitrogen, okay, because the majority of our atmosphere is made up of nitrogen. And so it does not dissolve into our blood as well as carbon dioxide does, as well as oxygen does. So gases, this is an important concept to understand, is gases, all right, that have a low solubility means we have to exert much more pressure onto those gases to literally force them to go into the liquid. All right, so for nitrogen, we've got to really put a lot of pressure on that nitrogen to force it to go into water. Whereas with carbon dioxide or with oxygen, we don't have to exert as much force. And with carbon dioxide, we have to exert even less force. That brings us to the bends, decompression sickness, right? We see this with divers, right? So they got their air tanks on, all right, it's made up of atmospheric gas. They're going to dive down, and they have to be careful because the deeper they go down, the larger amount of pressure is being exerted on them from the water. You've all probably, well, I shouldn't say you all, but for those of you that have ever been swimming in a pool, right, if you're in the deep end and you go down to the bottom, you'll notice more pressure on your ears, right, because of all that water that's above you, right? So as these people start to go down, if they come up too quickly, right, that nitrogen will come out of the solution. And when it comes out of the solution, it bubbles up. And that solution is in your blood, it's in your tissues, and it can cause damage to those tissues. So what they tell folks to do, all right, because you're not giving your body enough time to exhale, all right, the nitrogen out. So what they say is come up a little bit, all right, wait there for a certain amount of time, all right, continue your breathing, obviously, because you're underwater, exhale that nitrogen, give it time to come out of the blood and out of your tissues, and then start to swim up a little bit more, then stop, do the same thing. You come up slowly, and so you're decreasing the pressure. So when you decrease the pressure, that allows that nitrogen that's been forced into your blood and into your tissues, right, to come out of the tissues and into your blood and into your lungs so you can exhale it off. So folks that don't come up slow and disregard what I just said, they have to go into these hyperbaric oxygen chambers. And so these hyperbaric oxygen chambers will help to treat that. And they help to treat a number of disorders. For example, carbon monoxide poisoning. Carbon monoxide, all right, loves hemoglobin. So it can bind to hemoglobin easier, all right, than oxygen can. All right, problem is, all right, that causes an issue because you can get carbon monoxide poisoning, and that's potentially fatal. So people that do have carbon monoxide poisoning, if you put them in a hyperbaric oxygen chamber, pretty much what they're breathing in is oxygen. That oxygen will force that carbon monoxide off of the hemoglobin molecule, so oxygen can then bind to it again, and then you can exhale and get rid of that carbon monoxide. All right, last thing I want to talk about is the alveolar gas exchange, what we call external respiration. We're going to talk about, all right, pretty much what I was showing you in that picture before. All right, oxygen and carbon dioxide diffusing across that respiratory membrane in the lungs and in between the pulmonary capillaries there. So let's start off talking about oxygen first. Okay, so the partial pressure of oxygen in the alveoli is 104 millimeters of mercury. The partial pressure of oxygen in the pulmonary capillary is 40. So knowing the values now and knowing that oxygen, these respiratory gases are always going to diffuse down their pressure gradient, we can see that oxygen is going to move from the lungs, from the alveoli, into the capillaries across the respiratory membrane, always moving down its partial pressure gradient. If you don't know this, start this video again, and maybe even watch my previous video, okay? Moving down the partial pressure gradient. Pressure is higher in the lungs and the alveoli. It is lower in the pulmonary capillaries, so it wants to enter your blood. It'll do so until we reach equilibrium. And the nice thing is, this value always stays constant because you're going to keep breathing and you're going to keep bringing in new air. And that new air, once it reaches the alveoli, has a partial pressure of 104 millimeters of mercury. So it just keeps replenishing itself. So what happens with carbon dioxide? Well, same concept, different direction. All right, so the partial pressure of carbon dioxide in the alveoli is 40 millimeters of mercury. The partial pressure of carbon dioxide in the pulmonary capillaries is 45 millimeters of mercury. It's going to diffuse or move down its partial pressure gradient. That means it's going to move from the blood into the lungs. From the blood into the lungs. And guess what? Instead of, all right, just dealing with the constant level, all right, of carbon dioxide only in the alveoli, right, we are going to see the same thing here that we saw with with oxygen. Constant, because we keep replenishing, all right, our air in the alveoli. And again, this will always continue until equilibrium is established. This is what we're seeing. This is what I was going over with. 104 millimeters of mercury, all right, of the partial pressure for oxygen in the lungs, all right, 40 millimeters of mercury in the pulmonary capillary. Oxygen, follow the red arrow, boom. Carbon dioxide has, all right, 45 millimeters of mercury in the blood, 40 millimeters of mercury in the lungs, follow the blue arrow, by carbon dioxide. And then this floats away, 104 millimeters of mercury for the partial pressure of oxygen, and partial pressure of carbon dioxide is 40 millimeters of mercury. That floats through your circulation. And that's what we see. Okay, so what contributes, all right, to the efficacy, all right, for this gas exchange? Well, one, all right, you have a huge surface area, 70 square meters. That's roughly the size of half of a tennis court. That's huge. And we have a very thin respiratory membrane. Okay, very thin. I know that doesn't really mean much to you, 0.5 micrometers, all right, but trust me, it's very thin. So this brings us to our next concept of ventilation perfusion coupling, all right? How do we functionally adjust, all right, the amount of perfusion and ventilation, the amount of airflow and blood flow, all right, during our gas exchange? So ventilation has to do with airflow, and that is going to be, all right, affected by either bronchodilation or bronchoconstriction. So we're going to see dilation occur when we get an increase in the partial pressure of carbon dioxide coming into the lungs. So if our partial pressure of carbon dioxide is increasing, well then, you know what? We've got to dilate that area to get even more air in there, because we need to pull in more oxygen from that atmospheric air. So ventilation is airflow. Okay, keep that in mind. Ventilation has to do with airflow. And perfusion has to do with blood flow. So if we want to change our blood flow, then we are going to affect our pulmonary arterioles. And so we'll either cause, all right, vasodilation or vasoconstriction for the pulmonary arterioles. So the dilation will occur, right, when we see either a decrease in the partial pressure of carbon dioxide in the blood, or if we see an increase in the partial pressure of oxygen in the blood. So I'll show you a picture here real quick. This is what we're going to see here. Okay, when we're talking about ventilation, right? When we get an increase in the partial pressure of carbon dioxide in the air that you're breathing in, all right, that increases, we're going to cause bronchodilation. If we get a decrease in the partial pressure of carbon dioxide breathing in, all right, then we're going to cause bronchoconstriction here. Then when we're dealing with perfusion, we're going to be dealing with the pulmonary arterioles. So two things can cause the arterioles to dilate, either an increase in the partial pressure of oxygen or a decrease in the partial pressure of carbon dioxide. And then for constriction, just flip it. We get a decrease in the partial pressure of oxygen or an increase in the partial pressure of carbon dioxide. So I want to talk about emphysema for a moment, our first clinical view here. All right, emphysema, all right, is going to be a condition in which we have damaged the exchange surface area there. All right, and that exchange surface area is that pulmonary or those respiratory membranes there. So if we damage that surface, right, then it makes it difficult for that gas exchange to occur. So what will happen is inflammation. Now keep in mind, inflammation is not a bad thing. Chronic inflammation is, right? But what we're doing is the person that has emphysema has had chronic inflammation, something that has damaged that tissue. I wonder what that could be. Oh, I know what that is. Smoking. And so that chronic inflammation has now damaged these structures called the terminal bronchioles. That's the very end of the respiratory tree before you get to the alveoli. And so there's been so much inflammation there that it's caused permanent damage. And because of that, all right, we have now destroyed the elastic connective tissue. So because we have destroyed that elastic connective tissue, right, we have now hurt our compliance value. And then since we've destroyed some of that tissue there, we will have a decrease in the number of alveoli that are functional, and that decrease causes an increase in that physiological dead space there. And the end result is when these folks are trying to expire, right, they do so in a very poor manner. So they have to recruit their accessory muscles. They have to recruit the internal intercostals. They have to recruit, all right, a lot of those accessory muscles found on their torso there. So people that have emphysema have a barrel-shaped chest because they're pretty much relying a lot on the accessory muscles because the external intercostals and the diaphragm aren't able to get the job done. Because we need to expand, all right, that thoracic cavity. We've lost the elasticity, right? So exhaling, remember, exhalation is relatively a passive process. If we lose the elasticity, then things don't spring back to like they used to. So we have issues. All right, so what are some of the other diseases that we see that can affect the exchange of carbon dioxide and oxygen there in the lungs? All right, lung cancer, right? Big one that helps to, again, increase our physiological dead space because it can destroy, all right, those alveoli. Right? Pneumonia and congestive heart failure can thicken the respiratory membrane, which makes it much more difficult for the exchange of oxygen and carbon dioxide. All right? Anything that can cause changes in the ventilation perfusion coupling, well, asthma. That's me. All right, asthma, all right, can cause, all right, the bronchoconstriction. Those smooth muscles will cause bronchoconstriction there, and that will increase the resistance, therefore making it much more difficult for airflow to occur, specifically exhalation. Pulmonary embolism, that's an occlusion. That will also decrease airflow there. All right, so what we'll see is we're going to see a decrease in our partial pressure of oxygen because we're not able to ventilate and get the oxygen into the blood. And therefore, that's not going to slow down your systemic cells from still going through their normal metabolic processes. So we're going to see an increase in carbon dioxide. And not only that, it's going to be more difficult to exhale it off because, all right, the alveoli are damaged or the respiratory, the bronchioles there are undergoing vasoconstriction and increasing the resistance and making it much more difficult for air to move in and out of the lungs. All right, this is a good place to stop right here, folks. I will be sending out another video very soon, so keep an eye out. I hope you learned something. I'll talk to you soon.